Start off with a few announcements. The Stanford Lean Conference is coming up September 11th through the 12th. Registration is now open on the SMCI website. And if you have any questions, contact Lisa Freeman. And then if you submitted abstracts, Lisa said we should be hearing back very, very soon. So exciting announcements coming our way. Second announcement is July 9th. We are going to have Blaise Bush, the executive director of LGBTQ plus health program at Stanford Healthcare presents. So exciting presentation there. And then as always, please make sure to go to the SMCI website and make sure to join as a member or fellow to get these presentations automatically on your calendar. For today, we will be having, we are welcoming Dr. Michelle Lin from Emergency Medicine to present today. And Michelle is a winner of one of the winners of the SMCI Publication Award that took place and was announced earlier this year. Her paper won the award for Best Publication in Adult Population. Dr. Lin is an emergency physician scientist whose work strives to make emergency care more patient-centered, accessible, and equitable. Dr. Lin leads development of quality measures used by emergency physicians in federally mandated payment programs through her leadership roles in the American College of Emergency Physicians and Emergency Medicine Data Institute. Her active NIH-funded research projects develop new quality measures based on what matters most to patients, improve post-ED discharge care, and reduce readmissions for high-risk patients, and enhance health professionals' workforce diversity and retention. Dr. Lin has received several national awards for her work, including the 2024 ACEP Policy Pioneer Award and the 2001 Society for Academic Emergency Medicine Young Investigator Award. She completed her residency training at Bellevue Hospital Center in New York City, fellowship in health policy research at Brigham and Women's Hospital, and was previously a fellow at the Centers for Medicare and Medicaid Innovation. Thank you so much for being here, Michelle, and presenting your amazing work today, and I'll hand it over to you.
Thank you so much for having me. I'm just going to set up my slides. Looking good? Wonderful. Thank you so much to everyone for joining. I'm really excited to be here today. It's an honor. I wanted to present our work around leveraging quality measures to reduce health disparities in emergency care. As a little bit of disclosures, no financial conflicts of interest, and here are my sources of grant funding. And I'm presenting this work on behalf of a very large multidisciplinary group, so I'm grateful for the opportunity. So a little bit of background, as most of you know, there's really been a major focus on health disparities and health equity in the recent decade or two, with increased interest after the events of 2020 in the wake of COVID, George Floyd's murder. And much of this work has been around advocacy and quality improvement. And at the same time, there's been a movement towards paying for high quality healthcare, what we call value-based care, using quality measures. However, a lot of these quality measures have not been explicitly tied to disparities in equity. So there's a little bit of a mismatch in those two worlds. And given some of my leadership roles developing quality measures, it occurred to me that there hadn't really been any, careful thought as to how quality measures could be successfully measured to improve health equity. And so that was the genesis of this particular work that I'll be discussing today. As way of a little bit more background, I think many of us are aware that of the notion perhaps that quality improvement will improve care for everyone. However, that's just not always the case. And I think we've seen it time and time again with specific conditions. One example is the focus on hospital-wide readmissions reductions. We see greater reductions for white beneficiaries, for non-dual eligible beneficiaries. So there are racial and socioeconomic disparities. And then with respect to overall health, this is a slide showing changes in life expectancy. And as you can see over time, increases in life expectancy have increased for many racial groups, but for American Indian and Alaska Natives, it has not. So while overall life expectancy has improved, disparities in life expectancy have actually worsened. Really depends on the lens with which you're viewing this. And so I think there is a need for intentionality if you're going to be closing disparities in equity. And it isn't fair to say that quality improvement in general for all populations is sufficient to address equity. Um, and I think this, again, is not unfamiliar to most people on this call, this concept that health disparities are multifactorial, driven primarily by social and economic inequities. However, sort of on this far side of the spectrum in green, high quality healthcare does play a role. And what we do matters in terms of health outcomes for patients. So, um, what about emergency care and why does it matter? Well, um, the emergency department in the US is probably the largest provider of outpatient care. Uh, um, uh, it's about half of visits in 2021 and 22. So we're almost on pace with clinics, and continues to increase at a rate of 2% per year. US emergency departments see a disproportionately um, racial and ethnic minority population and lower socioeconomic status population relative to the rest of the United States. So, almost a quarter of US emergency department patients nationwide are comprised of non Hispanic Black identifying patients, and they visit USEDs at double the rate of non Hispanic white persons. Almost 40% of ED visits are insured by Medicaid, and depending on which study you're citing and which site you're at, 7 to 10% are uninsured. So relative to other healthcare settings, this is probably, with the exception of possibly FQHCs, the largest site for Medicaid and uninsured patients to access care. So where do disparities happen in emergency care? So pretty much at every step in the process, and this is a single slide to summarize a vast body of evidence, but we just see disparities in access and proximity to high quality, timely care. Even once patients arrive to the emergency departments, we see racial and ethnic disparities in triage scores, which determine how quickly patients are evaluated by providers, even after they're triaged and they're in the ED in a bed being treated by physicians. We see differences in imaging rates. For example, Black patients with abdominal pain are less likely to be imaged relative to white patients. There's some evidence that non-English language proficient patients are actually more likely to be imaged. And there's major differences in analgesia and treatment. So again, Black patients being less likely to be given analgesia for very painful conditions like long bone fractures. And then sort of along the continuum in terms of what happens to a patient and where they go after the emergency department, there are racial and ethnic differences and socioeconomic differences in who gets admitted to a hospital, who gets transferred to a higher level of care, and what facility they get transferred to, and who leaves against medical advice for a variety of reasons. So all of these factors contribute to racial disparities in health outcomes, and all of these factors are potentially influenced by emergency care. So we convened a task force with a couple of objectives. Our first objective was to look at the portfolio of existing measures that we're using that are tied to payment and identify the ones that would be most high yield to stratify by race and ethnicity to help close racial and ethnic disparities. Um, and we knew that existing measures were not going to be sufficient, so we wanted to come up with a way to develop new measures. And so we wanted to really develop a framework for how we could assess disparities, track them, and come up with new ideas. And then we wanted to use that framework to actually develop some gap areas and new measures. A couple limitations. So we're specifically focused on racial and ethnic disparities. There are a number of other disparities, such as in disability status, language proficiency, and socioeconomic status that we were not focused on. We're specifically focused on provider group level quality measures. I think a lot of you know that quality measures are sort of in different portfolios based on the measured entities. So we didn't feel like it was within our control to look at hospital level measures, for example. We were looking at provider groups. And again, we recognize that quality measures are one of many tools, but we really felt like this was an underutilized area, and one in which we could have direct influence. So we convened a really large group of folks with varying levels of expertise, and we essentially did so by using the American College of Emergency Physicians' existing committees and interest groups leadership. So we first tapped all the leaders of the diversity section, the social emergency medicine section, the quality section, quality improvement interest groups, and asked either them or an alternative leader who they identified to serve on this task force, and tried to also, of course, include some non-academic partners, since a lot of this work tends to be dominated by folks practicing in urban academic regions. And came up with a pretty diverse group, in my opinion. And we convened them for a several months process. They were first convened in August of 2021. We held a series of 3 meetings throughout that fall, 2 of which were virtual and 1 was in person at our annual scientific meeting. We drafted a report based on our findings and shared that with the society and all the groups, stakeholders for comment, and then ultimately published this for peer-reviewed publication. So I'll be talking about our results. So back to the first objective, to prioritize existing measures to stratify. So we did a pretty extensive literature review on how this could be done and found a sort of convenient National Quality Forum disparity sensitive quality measure scoring system that we adapted for our purposes. Interestingly, it had been published but never actually used. But it sort of gave us a framework for assigning a quantitative, somewhat objective value to different measures, and sort of going from left to right. One was relevance, just whether or not there's evidence of disparities in a particular quality measure. So one that I'll use, for example, that's very common in emergency care is use of a head CT for patients who hit their head with head trauma. So is there evidence of disparities? For this one in particular, maybe. 2 was impact. So this was most highly weighted. So whether or not improvements in this area will meaningfully reduce health disparities, has this successfully been done in any setting? And then consideration for prevalence and health disparity populations. So I sort of used that imaging example, and that one we didn't find a big difference. But for something like sepsis, for example, we did find bigger differences, not only with respect to sepsis care, but also, sepsis is a very prevalent condition in health disparity populations. So in this case, we were targeting racial and ethnic minorities. And there have been a number of efforts to meaningfully reduce both sepsis, improve sepsis quality, but also specifically improve sepsis disparities. The third category was equity weighting. So does it directly address inequity versus improving quality overall? And because all of these measures were initially developed for all populations, most of these scored essentially a 0. And then the far right is essentially feasibility. Can it be measured in an accurate, reliable, consistent, comprehensive way? Most of these measures scored relatively high because they were existing measures that had been in use and used for payment. So this was our process. So the measures that we selected, sort of like I mentioned before, were existing quality measures that were already in use for measurement of and comparison of provider group quality. So there were a total of 39 measures from the merit-based incentive payment system and cross-cutting measures from the quality payment program that had been used by emergency physicians historically. We had 2 reviewers review each measure, and then any disagreements were reviewed by a third reviewer. And based on that, we sorted the 39 into 13 high, 18 indeterminate, and then 19 low disparity sensitive measures. So at meeting 1, we started with very, basic consensus. Let's focus on the high and indeterminate ones, and we'll move forward without talking about the 9 low ones. And there was no objection to that. In meeting 2, we discussed all of the 18 indeterminate measures to see if those should be elevated to higher priority. And ultimately, none of them were retained. And then in meeting 3, and the in-person session, we used a dot voting process where each member got, I think, like 10 little dot stickers to prioritize which measures they felt like should be prioritized. And this was the outcome. And so the description of the measure is in column 2. The domain of the measure is in column 3. The measure type with respect to structure, process, outcome is in the next column. The final rank is in the second from right, and then their NQF disparity sensitive score was in the far right. And as you can see, the top scoring measure was follow-up care coordination documentation in the discharge summary, followed by a proportion of patients with psychosis and agitation receiving antipsychotics, followed by sepsis and stroke measures, respectively. And this is the rest of the list of the 13 that were considered top priority. And as you can see, many of these are very commonly used emergency medicine measures that align with things that we see a lot, like sepsis, stroke, trauma. A couple of comments. So you'll see from the prior 2 slides, the vast majority of these were process measures. So I think a lot of you are familiar with sort of the Donna Beating framework of structure versus process versus outcome measures, with structural measures being things that are inherent to the environment in which you're delivering care, such as resources, processes being things that, clinicians directly influence, but are not necessarily a patient-centered health outcome. There was a lot of discussion in the group about how process measures may actually lend themselves better to reducing health disparities because they directly measure the action taken by a provider in the course of care, whereas an outcome, for example, is influenced by many things, such as a patient's baseline health status and chronic health conditions. And so it may or may not be reflective of the specific action that we're trying to influence here. So, and this was sort of interesting because in many regards, we tend to want to focus on outcome measures, but when we're looking at a specific gap in terms of equity and care delivery, it may be more useful to focus on process measures. Other thoughts were that a lot of emergency medicine measures focus on overuse and efficiency, and to a lesser extent, cost. And these ended up being relatively lower priority because for a variety of reasons. One, there wasn't as much evidence with respect. Well, the evidence was mixed with respect to differences in overuse, and it really seemed like it was perhaps more like misuse in certain populations, with a little bit of a nuanced picture with certain more privileged populations, for example, being subject to overuse, and perhaps less historically privileged populations being subject to underuse. And so a lot of these quality measures are intended, for example, to reduce excessive CT use and radiation. The literature just suggested that these didn't really apply to racial and ethnic disparity racial and ethnic minorities who've historically been more subject to underuse. And then similarly, efficiency around getting patients, out of the emergency department quickly. While that's, patient-centered, it didn't necessarily factor into equity because, if anything, a lot of these patients are being undertreated. So our second objective was developing a framework to assess disparities and develop new measures. And this took a lot of brainstorming. For this one, we actually did pull in some feedback from a patient partner. And we really wanted to align this with how patients experience their journey through the emergency care. So we started all the way on the left with access and sort of all of the historical things that influence their decision to seek emergency care in the first place. And then, how it is that they arrive, because that already introduces some inequities. For example, how quickly they come in for their symptoms, how they come in, whether that's by EMS or by private vehicle. And then, once they're in the ED, how quickly their diseases are recognized, what the process of diagnostic testing and treatment is, how often they're screened and referred for social risks, and then their transitions of care. Where do they go after the emergency department? How are we making that decision? Are we effectively handing off that care? And then when we are sending these patients home, how effectively are we coordinating with community-based providers? Uh, and not just primary care providers, but other providers, whether it's therapists, substance use and behavioral health providers. And then through all of this, there is a lens of structural racism and bias that influences their care at each step of the way. And using this framework, we then moved on to the next step of identifying gap areas and developing new measures. The vast majority of these existing measures were from that care delivery center box, and there were essentially no existing measures in the access and transitions domains. So we really tried to brainstorm in those areas. So these are examples of the types of measures that might be developed. And again, these are organized into structural measures, process measures, and outcome measures. So examples might be access to 24/7 interpreter services, which is wonderful, and legally the standard, but not effectively implemented in many health care settings. Availability of on-call specialists. Again, we take that almost for granted at a facility like Stanford, but in a lot of rural and critical access emergency departments, that's just not the case. Process measures, again, what are the provider's actions resulting in potential health outcomes and disparities? And so whether or not interpreters are being used, whether or not there are racial and ethnic differences in the use of hallway beds, which we use in surge capacity, alternate sites of care, and then outcome measures. So racial differences in left without being seen rates. So patients who are waiting and simply, leave for a variety of reasons because, they don't feel like their needs are being addressed in a timely fashion. And then racial differences in transfer rates. Care delivery, while there were many already in this domain, we felt like there could be more. And the structural ones that we felt like were of particular importance, so the universal standardized collection of self-reported race and ethnicity data in electronic health records, and then similarly the implementation of clinical protocols for the care of disparity-sensitive conditions, and then some corresponding process measures. So again, how complete and accurate is the self-reported race and ethnicity data, use of stigmatizing language, adherence to the protocols, and then outcome measures, some of which the first one would seem similar, but the existing measures for medication, so this is for physical restraint use, patient experiences of justice involved individuals who often seek care in the emergency department, and then racial differences in left against medical advice treatment patients. And then care transitions. So access to 24/7 social work, uh, quality and completeness of handoff, completion of medically necessary follow-up, and then outcomes of risk-adjusted return ED visits, risk-adjusted inpatient ICU admission rates. And then the last one was structural environmental. So again, implicit bias training for clinicians, availability of social risk screening, referral and closed referral rates for those with identified social risks. And then this one was a bit controversial, but concordance between AD patient populations and the local community. Are you serving a community that looks like people, the community that you live in? A couple of key considerations that came up on the panel. There's a really strong emphasis on the fact that these should be used for quality and not certainly initially for financial penalties, because there's this problem of regressiveness in that the institutions that predominantly care for racial and ethnic minorities are more likely to be under-resourced safety net institutions in the first place. And so even though they don't do well, incentivizing them to do better should not necessarily be tied to removing resources from these institutions that are often already struggling as is. So we felt like reporting was very important, but penalizing clinicians was not. There was a lot of discussion on how to report and score this. So do you report, for example, the most historically advantaged group relative to the least historically advantaged group? Do you report, for example, only differences within a particular institution, or do you report, for example, performance across institutions, perhaps highlighting institutions that do well and those, above median, for example, in institutions that don't do as well? And I think I think the consensus was that we probably need to do both. So that was helpful. And then I think, again, this emphasis on complete and accurate data. For those of you, who may or may not be familiar with how race and ethnicity data are traditionally collected, it's in the process of registration. And historically, it's not been self-identified. It's been what the ED registrar believed the patient to be. And as we know, that's not the gold standard way to collect race and ethnicity. So there have been a number of case studies and quality improvement initiatives identifying a major gap with respect to knowledge and education among ED registrars and among patients. We're collecting this because there are health disparities, and unless we have the right data, we cannot track this. And Stanford had a very similar initiative in the last year or so, called We Ask Because We Care. So this is, similar to work that's been done in other institutions. So what are our next steps? Again, supporting quality improvement to improve completeness and standardization. When we look at the completeness of the race and ethnicity data that's been submitted for quality reporting, it's actually quite low. Only 20 to 30% of our ED sites are reporting. So that poses a major challenge. Two, to clean existing data. So there's a lot of variation. So the 20-30% is across all sites. We have some sites giving us 90% data, some sites giving us 0. So working with the data that we have to reclassify them according to federal standards, such as the OMB standards. And then the third step is to start engaging sites for testing and reporting. So we want this to be opt-in. Sites that are interested in reducing their racial and ethnic disparities, working with them to create dashboards for how they feel like is the most helpful way to display this information. So I'm happy to stop there and take questions. I have a couple of references, including our paper in that QR code Google folder.
Thank you, Dr. Lin, for a wonderful presentation and very thought-provoking, as many people on the call probably are faced with thinking about these standardized measures that we use in healthcare, and are they applicable to every use case we can determine, and here being equity. I'd like to open it up for questions, and I don't know if Lee Stone could come off mute. Both of your questions were insightful, and it'd be great if you could ask them. Otherwise, I will.
Yeah, I don't mind coming off mute.
Great.
Thank you, Dr. Lin. It's a pleasure to see you again and hear this great work. I did have a couple of questions. The first one was about representation. It looked like the team that you put together was exclusively or mostly physician-led. Did your team consider adopting a community action approach or interdisciplinary approach to capture the perspectives of other stakeholders?
Yeah, that came up, and we did circulate the draft report among community and non-physician stakeholders for comment. But we felt like because the quality measures were developed and intended for use in the measurement of provider performance, that the core panel group would consist of providers. We did not include non-physician providers, and that was probably an oversight, but there has been some controversy over that in recent years, and given that the society that was sponsoring this effort was a physician-led society, that sort of was a practicality. Yeah, I think that's a limitation and something that is a trade-off.
Yeah, thank you for that. And then I had one more question that I thought of, mostly about your methodology. You mentioned that you are moving or thinking a lot more about process outcomes, but how do you determine if your interventions are appropriate and effective if they aren't tied to a realized outcome? Are you doing something akin to like a double check here, like the process improved, the outcome improved, so we're good, versus the process improved and the outcome stayed the same or worsened, so maybe that wasn't the right process? How are you making sure that your process is that you're improving is the right process?
Yeah, that's a great question. So we sort of have a problem overall in emergency care in the sense that we don't have a lot of great outcome measures for emergency care specifically. So if you think about a lot of the really high stakes conditions that we treat, like sepsis, stroke, or heart attack, a lot of that. A lot of the outcomes associated with that care, so mortality, readmissions, functional outcomes, those are really influenced by many other providers, such as inpatient providers, outpatient providers, and the certainly emergency care plays a critical role in that. But how do you tease out the proportion of quality that is driven by the emergency provider relative to the rest of the healthcare system, and then also not even factoring how do we risk adjust. So that's sort of like the background of the problem, is that we just don't have great outcome measures in general for emergency care. There are a handful, like reduction in lactate measurement for sepsis, but really that's a very small part of the process, right? Like you can't even attribute sepsis mortality or like in-hospital mortality to emergency physicians. So we have this bigger picture problem of like, how do we measure outcomes of emergency care? So yeah, I think we tried to move towards more outcomes, particularly with the new measures, and some of which could be directly attributable to patient care. So patients who leave without being seen from the ED, patients who leave against medical advice, differences in transfer rates, admission rates. But again, these are driven by a number of factors, right? So like, are you leaving against medical advice because you didn't like the care you were receiving, or was the care actually bad? Or did you not trust that provider because of historical mistrust issues? Were you transferred to a different facility because of your insurance status, or was it patient preference, and was it driven by the time of day and the specialist availability? We felt like again, outcomes are just so much more multifactorial, harder to risk adjust, and harder to attribute to emergency provider specific care. the focus on process measures, specifically to close racial and ethnic disparities, would be higher yield.
Follow-up on that question is, since you are with this set of measures moving to more process, is that creating the limited data access this group seems to have, with only 20 to 30% being able to capture these measures currently?
Yeah, so these measures for the most part are being offered. We have like, I think 800 to 900 EDs that are contributing data to this quality registry, spanning sort of mostly smaller to medium-sized EDs. So with respect to the measures themselves, we have obviously good reporting on the specific data that we need to calculate the measure. It is the race and ethnicity and insurance data actually that's not as complete and not as high quality. So I think that's the big push, is how do we get sites to see that this is important, do this well? We don't really have I mean, we have frankly debated quality measures around completeness of race and ethnicity, and we may still consider doing something like that. But again, I think we have to recognize that sites have different resources, we want this ideally to be a carrot and less like a stick. Although unfortunately, many quality measures do seem like sticks.
Hey there, this is Nazima from Palo Alto. Thank you so much, Dr. Lin. This was an awesome presentation. I just had a comment/compliment. I think you explained so nicely how the combination and emphasis on the process measures really hones in on the things that we as clinicians and staff can actually affect, where so many factors can feel out of our control and frankly overwhelming or even demoralizing when the focus is so much on the outcome measure. So I just wanted to applaud you for that. And I'm a hospitalist, and we have access to outcome measures, but we don't have much access to process measures. So I think that's been a challenge that it looks like you have been able to get data for process measures. So that's fantastic. The other comment/compliment I wanted to give was just moving forward in the absence of perfect data, or even data that may be of the same quality, integrity, quantity as other measures. And that saying, not letting perfect be the enemy of good or better. So thank you. You've given us a lot to think about, and how we can apply some of these things on the hospitalist side. So thank you.
Thanks so much.
Marcy, did you have a question?
Yeah. Hi, Michelle. That was a great talk. I have a question, and I apologize if you answered it. I had to step out. I was trying to get lunch. But some of the measures, some of the process measures in particular, I think looked like they would be hard to actually capture. I think one of them was something like about the patient experience with being treated poorly because of race, something like that. And I'm just wondering how people are collecting that. Is it through an after ER visit survey, or is someone talking to some random sample of patients, or like what's happening with that?
Yeah, that's a great question. I think patient experience is tricky in all settings of care, and particularly in the ED. It's probably similar to what happens for inpatients in the sense that patients get either sort of My Health or mailed survey, and the response rates are terrible, and primarily driven by patients who have extreme experiences. So you get a very skewed sample of positive and negative experiences that are not that representative. And you see a lot of I think let's say differences by different provider type and so on, and patient demographics. So I don't think we have great solutions for how to measure patient experience well. There was a lot of discussion in the group on how to measure more patient-reported outcomes, though. So sort of not quite the experience of healthcare itself and not necessarily a satisfaction, but there hasn't been a lot in emergency care in general to look at patient-reported outcomes. And I think that's something that we can do better, and there aren't great measures for, but there are a lot of things that we do that influence functional status, symptom improvement. I think about diseases like back pain or headache, where people come in with a discrete treatable sort of syndrome, and something that we do can make them better. So that's pretty far from real world implementation, but I do a lot of that in my personal research, and it's certainly challenging, but I think it's sort of a future state that we'd like to move towards.
Just a quick follow-up. Did the committee discuss how all these measures would be collected, like kind of the feasibility of measuring, collecting? Because again, like some of them look pretty easy, low-hanging fruit, and others looked there were I don't know, 3 or 4 that I thought, gosh, how are you going to collect that? And it's a great goal, but I'm just wondering, like, how close is like the goal and the reality?
Yeah, I think those are great questions. So in general, the movement has been towards focusing on electronically collected quality measures that can be done without any need for manual chart abstraction. Using structured data elements that are already available in the electronic health record. So a lot of the proposed new measures don't fit that category, right? And then I think they're in the process of measure development. We don't necessarily restrict ourselves to electronic quality measures. I think we consider the trade-off, like, is this a major enough quality gap area where the additional work spent to do the manual chart review and abstraction, or to do the free text electronic search, which is imperfect, right, for unstructured data, is it worth the trade-off? Can we capture it accurately enough at a large enough number of sites to show a quality gap? And so I don't think there's any single answer to your question. I think we try to weigh each measure on its own. We actually currently don't risk adjust at all with a lot of these electronic quality measures, because we don't always have access to historical patient data that you might have if you were doing, for example, a claims-based measure the way that CMS does readmissions, right? So a lot of these EDs are only submitting data from that visit. If that patient happened to have prior visits at that specific hospital, you might get historical data, but it's really a very thin snapshot in time. So to effectively, adjust for the totality of a patient's history that might contribute to differences in quality is pretty hard to do. Hence, again, to some extent, the focus on the outcome measures. But again, I think this sort of trade-off between what do we know we can do well, accurately and fairly, and doing our best to put that out there.
Sophia, did you come off mute to ask a question? Lee, I would love to learn more about your comment in the chat.
Yeah, sorry, I like to ask a lot of questions. I apologize. Don't let me monopolize all the airtime. No, I'm not entirely sure that I completely agree that outcome measures are very out of our control. And I say that because I think that so much of what we do as healthcare providers in hospitals, we orient ourselves to the hospital, the physical space that we're working in. And patients' lives are not oriented to the hospital. In fact, most of the times when they come into the hospital, it's something they do not terribly voluntarily, and it's not in any way, shape, or form something that they want to do frequently. So, I think that those areas where we think might be out of our control, my background's in heart failure, And we talk a lot about patient diet, and patient diet's often listed as, well, I can't police what they do at home. But there are innovations out there. There are creative ways of thinking that have been implemented to sort of meet the patient in their space, to have more control over those things that we think we don't have control over. So, I just wanted to get your ideas on how we can, if we don't have good outcome measures, how can we find good ones? And are the outcome measures really, really out of our control? Or
Yeah,
is
I
that...
guess yeah, let me maybe back up a little bit. I don't think I intended to say the outcome measures are out of our control, or that we shouldn't be measuring them at all. I think that they're harder to do and harder to do well. And when you're trying to improve a specific care process, it may be more useful for a provider to understand, well, where in the patient's trajectory of care and their episode, where is the breakdown happening, right? Because if, I'm going to use readmissions as an example, because I think it's a commonly used one, like, okay, like this patient, our readmission rate is high for this population at this facility. Like, okay, well, where is the breakdown happening? Is it that they're not making it to their follow-up provider? Is it they're not filling their prescriptions? Is there some lack of understanding with respect to diet, right? And so if you can distill it down into these processes that help us understand where in the process of care that disparity is arising, right, then it more easily lends itself to a quality improvement process that might close that racial and ethnic disparity. But I'm not saying that we shouldn't measure outcomes or that we aren't responsible for them. I do think that, they are within our control as a system and as providers in partnerships with our facilities and our communities that we can certainly, that is certainly the goal at the end of the day.
Great. Seth Cohen says the My Health team would be happy to talk about how to improve transitions of care out of the ED. Thank you for offering that, Seth. And we have like 1 minute left, so I'm going to hog the question for myself. Thinking locally, how have you taken what you did with this national group and operationalized it at the SHCED, and maybe just like one example of how this has like led to an improvement or the start of an improvement?
Yeah, that's a great question. And this is something I think about a lot because I consider myself a researcher and not necessarily a clinical operations leader or a quality improvement expert. And so I think I'm at the point where I'm starting to have conversations with a lot of our ED clinical leadership about, I think what I know from my research and policy work and how that can be realistically implemented in a setting like Stanford. But I think that that's a sort of like a research to translation gap that is unfortunately common across disciplines, and it's not an excuse. I think it's just like, we tend to sort of be good at what we do and stay in our silos. And I'm certainly doing an effort to reach out more.
We're at the end of time, but if anyone has a burning question, please pop off mute.
Happy to chat offline with anyone. Just drop my email again in the chat. Thank you so much again for having me.
Thank you. Thank you, Michelle. And I hope to see everyone July 9th, as well as at the Lean Conference in September.